I created this video to talk you through radical prostatectomy. In clinic or the morning before surgery, we're going to go over things at a relatively high detail, and I hope to explain a little bit more in detail to you on this video. If you have any questions or you want to go things in further in person, feel free to ask questions. So radical prostatectomy refers to removal of the entire prostate for cancer. That's the traditional way we've done this operation for now over 100 years. Radical refers to the fact that the operation is done for cancer, and it refers to the fact that the entire gland is coming out. It shows up in multiple locations in the prostate, and for that reason, the vast majority of men who are undergoing prostate cancer treatment are going to have their entire gland removed. The indication for surgery, or therefore the reason to do surgery, is most typically to cure men of prostate cancer. And for most men with clinically localized organ confined disease, surgery is going to be curative. There are men with higher risk prostate cancers, particularly men with Gleason 8, 9, and 10, but we may pair or plan for surgery with radiation or additional therapy down the road to offer a man the best chance of cure of his cancer. The vast majority of radical prostatectomies in this country today are done robotically. That's the way I do all of my operations for over the past decade. I have not had to convert to an open radical prostatectomy in well over a decade, and I don't plan on having that happening anytime in the near future. The traditional way we do the operation is through a multi-port surgery, meaning multiple small incisions across the abdomen. Traditionally, the way I do my operation is 5 small incisions across the abdomen, one at the belly button, 2 on each side. That allows us to place 4 robotic instruments and an assistant port so that our assistants can hand us things in and out during the operation. Additionally, most men will also have a very small incision in the upper right quadrant of the abdomen. That, once again, is an assistant port that allows our assistant to typically pass in what's called a sucker, or something to help us visualize during the field to clear any blood or urine that may obscure our view. Once we start the operation in its simplest form, where taking the urinary system apart, it's inherent to the operation that seminal vesicles come out. They make most of the fluid that accompanies sperm in the ejaculate. And so, with the prostate gone, there really is no reason to leave the seminal vesicles behind. And it's an important part of our cancer staging in circumstances that prostate cancer does invade out of the gland into the seminal vesicles. Most men are getting a lymph node dissection, that is removing the pelvic lymph nodes on either side of the prostate. There's something we call the anterior fat pad. There is fatty tissue that sits above the prostate, so we'll send that off for analysis, and then we'll do the right side and the left side. These are lymph nodes that surround the internal and external iliac blood vessels, as well as the obturator nerve. We'll talk about risks later in this video, but that helps us once again accurately stage prostate cancer. If we know that a man has cancer in their lymph nodes, but our imaging and our testing isn't perfect. And so we typically remove those lymph nodes to be 100% certain we have accurate staging and completely understand your cancer. Once the prostate and seminal vesicles are removed, we need to reconnect the urinary tract. That involves reconnecting the bladder to the urethra. That gives you the best chance at continence. And so when you wake up in the recovery room, you're going to have a catheter in. That catheter is in typically for about a week. We know every day we remove it under a week increases the likelihood of a man going into urinary retention, because there can be some swelling and what we call edema or fluid buildup around that new connection. 7 days is about the sweet spot for that catheter to be in. So you'll wake up with that catheter in. When you wake up in the recovery room, you may feel like you have to urinate. That's your body getting used to the catheter. That sensation typically passes within 2 to 3 hours of the operation. You may also feel like you have to have a bowel movement. So when we remove the prostate from the rectum, or from that area, there can be some inflammation in some men depending on how close their prostate sits to their rectum, and that can make you feel like you have a bowel movement. Those sensations will typically pass within 2 to 3 hours of being in the recovery room and typically go away as we get you up and ambulatory after surgery. To do what we call anastomosis or connection, we will sew with absorbable sutures the bladder to the urethra, and we may have to do some reconstructive techniques depending on somebody's anatomy, how big their bladder or bladder neck is, that allow us to bring that bladder and size it down to meet the urethra. We try to preserve bladder neck size, so we try to make a small bladder neck to align it with a relatively small urethra. We use absorbable sutures in a running fashion, and we do a technique called intussusception, which has been around for decades and it's borrowed from the open experience in a way to help kind of bolster that recovery and help bring our men early urinary recovery. The next big thing we talk about is kind of your recovery. For the vast majority of men, this is an overnight stay in the hospital. Healthier, active men can often go home the same day In surgery, we learned during COVID when we couldn't keep people in the hospital that it is safe to go home. Though we will tell you, you will have to walk, you will be moving, and 6 a.m. in the morning after surgery, you'll be uncomfortable, whether you're in your bed or our bed. But the understanding that that's related to the surgery, that's related to the robotic arms as they move around your belly and what's called insufflation or gas that we need to put in your abdomen to be able to see is what causes that soreness. The good news is it's muscle soreness. And as you get up and moving, that discomfort typically subsides by 7, 8, 9 o'clock in the morning. And so if you're in the hospital with us, the vast majority of men are being discharged late in the morning. While the catheter's in, we want you up and walking and active. Even though this is a minimally invasive robotic surgery, it is a big deal to remove a prostate and reconstruct a urinary tract. So naps are to be expected. And if you're tired, you should be napping. You should give your body every opportunity to heal and rest. However, when you're not napping, you should be up and walking. The more active you can be, the more quickly you will recover. A week later, that catheter will come out, and then we'll start working on your urinary control. We'll start coaching you in that first day on how you can hold your urine, how you should be going to the bathroom relatively frequently to exercise those bladder and sphincter muscles. And we encourage you to don't get discouraged in the first few days. It is very common to see leakage in the first few days that will subside pretty quickly. And then it is typically weekly improvements after the first few days. Basically, when the belly muscles squeeze, it'll force urine past the sphincter muscles as those muscles are regaining control. And that brings and over the next few weeks, we expect your activities to just continue to improve. By a month, you should be doing most of the normal physical activities that you were doing before surgery. We don't want you doing any strenuous activities, particularly with your core muscles for those first 4 weeks, because we want that new connection to heal. We don't want you to create any undue stress that can put pressure or tear apart that new anastomosis. If you do, that could cause a lifetime of problems with urinary control. So for a month, you're taking it easy. After a month, you can resume normal activities as you see fit. And depending on your urinary control and how well things are feeling, it just depends on how quickly you're going to get back to work or your activities or golf or whatever it may be. It's a great segue into our next big topic to discuss, which are what are the risks of the operation? What are the potential complications? We talk about pain, infection, bleeding. As a system, we do well over 1,000 of these operations per year. Our risk of having one of those complications is less than 1%. Very low infection risk, very low risk of blood transfusions with this operation, even though that risk is unlikely. And our pain is pretty well tolerated. About 50% of our men will go home without narcotic pain medications. Those that do typically go home with just a handful of pills to help with the first few days of discomfort. We judge that based on how much uh, pain you're in the recovery period and how much pain medications you need when the specific things we talk about with prostate cancer surgery. The biggest one is urinary incontinence. And as I said, when that catheter comes out, most men are going to experience stress urinary incontinence or leakage of urine with cough, sneeze, physical exertion. That's where kind of the peak of our recovery curve is. It can take as long as 6 or 12 months for some men to gain urinary control. And a handful of men, depending on age, will permanently leak urine. So at a year, they're requiring either a pad or a diaper, or we're talking about doing a procedure to tighten things up. Those numbers modulate or change with age. So younger men are more likely to get their urinary control back a little bit quicker. They are less likely to have long-term incontinence. Older men, particularly men in their 70s, will see a longer recovery. So the peak recovery is typically closer to 6 months where they're getting urinary control back. And a slightly higher proportion of those men will experience long-term urinary incontinence. There are lots of things that go into this, which is why it's so hard to predict. Some of it relates to how big and strong your bladder is before surgery, because many men are dealing with big prostates as we age. It also has to do with kind of your anatomy and which muscles we're able to preserve and which muscles need to regain control as we age. And one of the ways I always like to think about this is there are 5 sphincter mechanisms for men. When we do prostate cancer surgery, we're disrupting at least 4 of those mechanisms. Now, women in general have one muscle called the external sphincter that controls their urine. After prostate cancer surgery, so the vast majority of men should be continent. We just need to retrain that muscle. And sometimes what determines the quickness to recovery is how much you were using that muscle before surgery. It's really hard to predict that. We don't have any good tests to be able to test how strong that muscle is prior to going to the operating. The next big category of risk we talk about is sexual dysfunction. So we disconnect the urinary and sexual systems with this operation. We don't change sensation or ability to have an orgasm, but no fluid will come out because we disconnect the urinary and sexual systems. Every man who I take to the operating room is a candidate for bilateral nerve sparing surgery. That means preserving the blood vessels and nerves on both sides of the prostate that allow normal erections to happen. I don't base my decisions on nerve sparing based on your MRI or imaging prior to surgery, based on what we see in the operating room. We may not be able to as aggressively spare nerves and blood vessels on that side, but I don't make that decision until we get into the operating room because in a fair number of men, it really depends on what the tissue feels like and looks like. That's what determines our ability to spare nerves effectively. Now, sexual function in terms of erections is a much longer recovery process. We measure urinary control 1 year after an operation. We measure sexual recovery function 2 years after surgery. For most men who have good erections before surgery, in my practice, about 70 to 80% of those men are having erections sufficient for intercourse afterwards. About half of them are taking Viagra or Cialis for an additional boost to help with erectile function. We will be aggressive with what we call penile rehabilitation or helping you with regaining sexual function or erectile function after surgery. That means we can start an oral medication like Cialis or Viagra. Those medications certainly can improve blood flow, even if you're not seeing an active erection early on. If you're really interested in early sexual activity and the pills aren't cutting it, we quickly move towards injectable therapy. While it doesn't sound like fun to inject a medication into your penis, this is basically high dose forms of Cialis and Viagra that go directly into the penis. They work really well. They help maintain blood flow and penile size, particularly during the early recovery period. Very common to notice what we call penile shortening or decrease in length of the penis after prostate cancer surgery, but it is a common thing that men experience. It is not related, as many men think, to kind of the surgery pulling the urethra back or pulling the penis backwards. In fact, the penis is kind of fixed to the pubic bone. What happens is because the nerves and blood vessels are disrupted during that surgery, there's less we call innervation or less messaging going to the penis. So it basically doesn't have the constant tone from the neurovascular system to be its normal length and width. For some men, that will improve with time, and for some men, that is a permanent change. Early penile rehabilitation or early recovery of sexual erectile function can often help with some of the penile shortening that we notice. Rarely we can see changes to the penis that are curvatures. That is called Peyronie's disease. Often that is a temporary finding that gets better over the course of 6 to 12 months, although occasionally that can be permanent after surgery. And once again, we have lots of fixes for that if you're in that rare circumstance where you notice a curvature to your penis that makes it difficult to have intercourse. Other very rare complications that can happen during prostate cancer surgery happen with laparoscopy or the fact that we're doing a laparoscopic surgery. So there can be inadvertent injuries to intestines. There can be inadvertent injuries to blood vessels. The rectum, once again, sits right underneath the prostate. The risk of those injuries are really low, but we have to tell you things can happen that we can't always predict in the operating room. The other risks worth talking about are related to the lymph node dissection. Typically, a really simple part of the operation adds on average 15 to 30 minutes for us to remove lymph nodes from both sides of the pelvis or problematic bleeding from those areas, but that certainly can happen. There's a big nerve called the obturator nerve that we work to preserve, although injuries to the obturator nerve are also rarely reported. It doesn't have a big impact if that nerve is affected in terms of daily function, but it allows us to squeeze our legs together. So for cyclists or motorcycle riders, it could affect your ability there. Otherwise, typically not a very impactful nerve, to be honest with you. There can certainly be lymphatic leaks or what we call lymphoceles after surgery. Most lymphoceles kind of get better on their own, or lymphatic leaks can get better on their own. But what they can do is increase the risk of deep venous thrombosis or blood clots because it causes pressure on those veins as they drain. One of the signs of lymphoceles is persistent fevers or pelvic pain. Please let us know. All it involves is us sticking you in a scanner and taking a look at your pelvis.